Good afternoon. My name is Ninez Ponce, and I am the director here at the UCLA Center for Health Policy Research. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tovaangar, that is, the Los Angeles Basin and South Channel Islands. Thank you all for joining us for the California Health Interview Survey 2021 data release. If this is your first time joining us, a big welcome to you. To those who have joined us for many years, thank you for your ongoing support. Before we dive in, I wanted to take time to recognize Hispanic Heritage Month and Filipino American History Month, which celebrate the history, culture, and contributions of Hispanic, Latinx, and Filipinx people. Now, the California Health Interview Survey, also known as CHIS, is the largest state health survey in the nation and provides actionable data on the health and healthcare needs of California's diverse population. Legislators, policymakers, local health departments, state agencies, community organizations, foundations, researchers, and many more rely on CHIS to make informed decisions. They rely on CHIS to advocate for resources and to ultimately improve the health and well-being of all Californians. 2021 was another challenging year. The 2021 CHIS takes a closer look at critical issues across the state with never before seen questions on gun violence, firearm safety, housing insecurity, climate change, childhood experiences, and encounters with police, as well as the ongoing health, financial, and social impacts of the COVID-19 pandemic on Californians. How are extreme weather-related events affecting people's physical and mental health? What are the rates of psychological distress among people who have had encounters with police? We'll dive into how these topics continue to impact people across the state. My colleague and our California Health Interview Survey Director, Mr. Todd Hughes, will walk through 2021 survey methods and key findings, and Senior Public Administration Analyst Sean Tan will share findings from a fact sheet that unveils some of the greatest concerns over gun violence and safety among Californians. Today's webinar is being recorded and will be posted to you over our YouTube channel in the coming weeks. As always, the recording and today's slides can be requested from our communications department by emailing healthpolicy@ucla.edu. We do have some members of the CHIS team today monitoring and responding to some audience questions in the chat. We will reserve the last 15 minutes of the webinar for the Q&A, and we do encourage you to ask questions throughout the presentation using the Q&A function in Zoom. Before we begin our presentation, I'd like to share a couple of upcoming events. One of the center's key goals is making our data accessible to everyone. On Wednesday, October 26th, we will host a CHIS data user training to demonstrate how you can use our free online tools to get data on a wide range of health topics across many sociodemographic factors. The UCLA Fielding School of Public Health and Center for Healthcare Management at UCLA will host the next Paul Torrance Health Forum on Wednesday, October 19th. The event will be focused on gun violence, and I will be sharing more of the findings on gun violence and firearm safety and storage from today's presentation, along with other presenters. We also ask you to save the date for the 2022 E.R. Brown Symposium, hosted by the UCLA Center for Health Policy Research. For some of you here who don't know, Dr. Brown is the founding director of the UCLA Center for Health Policy Research and the founding PI of CHIS. So this year's symposium will be held virtually on December 12th and bring together leaders from across the country to discuss gun violence as a public health crisis. Presenters will discuss research-based evidence on policies that have a positive impact on gun violence and policies that California may want to consider implementing to address the pressing issues in gun violence facing our state. Additional information, speakers, and an invite to come. Again, thank you for joining us today. Now let's begin today's discussion. Todd? Oh, no, I'm going first. So, what is CHIS? CHIS is the nation's largest state health survey. It's the most comprehensive source of health information on Californians. We ask Californians about a range of topics on health status, health conditions, health access, as well as a lot of what I call the backstory of what produces health and what produces health inequities, backstory on social determinants of health. And you'll see some of these questions today. So CHIS is a collaborative project funded by the federal and state health agencies, by California and national foundations. And for sponsors out there, we thank you, and many others. A report of 2021 CHIS impact showed what the volume of access to our data tools, Ask CHIS Neighborhood Edition, some of our health policy reports, our data dashboards, for example, legislation and advocacy that use the CHIS data, seminars, events, and presentations in the scholarship field, journal articles and publications, and of course, media coverage. And the numbers here are highlighted, the volume of the usage of CHIS and how we're making an impact. Next slide. So CHIS, for those of you new here, it's a survey that interviews adults and adults provide information for their child ages 0 to 11, and adolescents in the household provide their own information. So we have information on the whole age range of 0 to and up. So CHIS is conducted in multiple languages. It is conducted in English, Spanish, Cantonese, Mandarin, Korean, Vietnamese, and Tagalog.
Okay, thank you, Ninez.
Yeah, I called you in too soon, but here you are.
Great. Well, I'll share a little bit more background about how CHIS is conducted, and then we'll go through some information about the data that we're here to highlight today. So the design of the California Health Interview Survey includes a multi-mode data collection method. It's based on address sampling, so address-based sampling, and we use multiple modes of data collection, including web and telephone response, to ensure the highest possible cooperation rates at the most efficient use of resources. And this is a two-phase process that begins with initial set of 4 mailings that are sent to each address selected for the sample. And in those mailings, we select 1 sample adult to respond, and we give them the option to participate online through a URL or to call in and complete the interview by a toll-free telephone number. After those 4 mailings have run their course, if we're able to match a telephone number to any of the addresses that haven't yet responded, then we'll make a series of outbound call attempts to those households, with up to 6 call attempts being made to each. We use a number of different approaches to be sure to reflect California's diversity. And the quote at the bottom of this slide, I think, beautifully describes that vision, and it comes from that CHIS Making an Impact report that Ninez referred to. And that is that the state's population is a diverse tapestry, and for 2 decades, CHIS has studied its individual threads, namely data on the varied and specific health needs of different groups, particularly those that are underserved. And we have a number of tools at our disposal to be able to do that, including some targeted sampling methods, both for the main address-based design, as well as some supplemental sampling efforts that I'll describe in a moment. Multi-mode data collection, so that those who would prefer to answer by web can do so. Those who would prefer to answer by phone have that as an option as well. Language support in the languages that were described on the earlier slide. Custom oversamples where we can really drill in on certain geographic areas or subpopulation groups to get more information about their needs. And even follow-on studies where we can return back to former CHIS respondents and ask additional questions about their situation and our needs. How have those multifaceted efforts to reflect our diversity paid off? Well, this table demonstrates by racial and ethnic groups the sample composition of the 2021 survey. We completed interviews with over 24,000 adults in the course of the year. And we also spoke with about 1,100 of their adolescents in the home. And we conducted interviews in regards to just over 4,000 children for these households through a sample interview with their adult parent. So as you can see, we have a pretty good representation across each of these racial ethnic groups, thanks to those efforts that we make to do so. I'd like to describe a little bit more information about some of the supplemental methods that we used in 2021. One exciting new method that we used was the addition of a prepaid cell phone sample in addition to our address-based sample design. So this prepaid cell phone sample had a goal of obtaining interviews from over 500 completed adults in their households. And the real objective of that was to increase representation from certain characteristics that tended to align often with prepaid cell phone users. And that included those young adults age 18 to 24, respondents who identify as Hispanic or African American, or those who would prefer to take the survey in one of the non-English languages that CHIS supported. We're very excited that we were able to add this supplemental feature to our sample design in 2021, and we're continuing to use it today. Another targeted oversample that helped to provide additional insights from the survey includes some geographic-based oversamples in San Diego County, as well as Los Angeles Spas 1, 2, 4, and 5, which aligned with the Cedars-Sinai service area. And specifically, we were looking for additional interviews from Latinos and Asians age 50 plus in those areas in order to raise the total sample for those groups up to 800 interviews in 2021. Additionally, we conducted a study of an additional 125 American Indian or Alaska natives who lived in rural areas across California. So it's hard to really grasp how much data is available as a part of the 2020 data release that we're doing today. And to give you a sense of that, I'd like to share that there are 368 different variables or topics that are included in our Ask CHIS platform. And in that platform for 2021, you can cross that by any other of those 368 variables to create cross tabulations and really see how different factors interact with each other. And then you can examine that for each of 66 different geographic areas in California. And so if you were to do all of that, you'd have approximately 9 million different CHIS estimates that can be explored in our online system. So it just boggles the mind at how much data is really available for anyone in the state to use to understand the health and influences on health across California. Relatedly, there's also a public use file that's being released today that contains over 1,285 detailed variables for specific research for each of those 24,000 adults and adolescents and children that I described earlier. So there truly is so much to be able to explore. It's impossible for us to really give you a sense of everything that's in the CHIS questionnaire in this webinar, but we do want to point out some noteworthy additions that were made for the survey starting in 2021. This slide summarizes some new content on the left in the adult questionnaire, as well as some reinstated content on the right, which are questions that previously appeared on the CHIS and then returned for 2021. A number of interesting topics related to climate change, firearms, as Ninez described in the introduction, as well as CBD use, adverse childhood experiences, paid family leave, et cetera. And we'll talk about some of these topics in our data highlights momentarily. Some of these are released in our public use files, others are available through the Ask CHIS platform. But for the most detailed and sensitive questions, access to that confidential data regarding those items are available only through our secure data access center. And then additionally, we have new topics and questions for the adolescent survey as well as the child survey. I won't read through all of these together for you today. There is a lot of overlap with the adult survey. The child questionnaire has new topics on book ownership, sources of reading materials, and challenges to reading, as well as number of dental visits in the past 12 months that are unique and different for that survey as well. One final change to the questionnaire that I do want to highlight for you is that in response to changes made to the 2020 US Census form, our CHIS 2021 questionnaire added 2 more detailed questions to collect origins for those who responded white or Black or African American to the basic CHIS race questions. And those questions that we added are listed on the right side of the screen. So in these open-ended write-in fields, we then captured the first 6 responses that were written in and coded those. And the adult public use file then that was released today includes new variables that identify Middle Eastern or North African respondents, as well as those who identified as Black Caribbean and Black Sub-Saharan African, according to the census's definitions for those. And if you want to be able to conduct research using all 6 of those detailed responses, that's available through the Data Access Center. All right, now I know you've been looking forward to it, so I'd like to share some of the information on our highlights of what the data from CHIS 2021 show. CHIS 2021 data collection occurred throughout most of the calendar year from March 18th through November 30th, which covered a full second year of the impacts from the COVID-19 pandemic. That allowed us to measure the pandemic's cumulative impact on the mental health of Californians. And when comparing the same CHIS mental health indicators in 2019, prior to the start of the pandemic, the CHIS 2021 data show significant changes in mental health and access to mental health services. Specifically, we identified that 1 in 4, or 25% of California adults said there was a time in the past 12 months that they felt they might need to see a professional because of problems with their mental health, emotions or nerves, or their use of alcohol or drugs, an increase from 21.6% of adults prior to the pandemic. California adults use different tools to address these mental health needs at increasing rates in 2021, such as 9.3% who used online tools to connect with a mental health professional compared to 5.6% in 2019. Additionally, 11.6% took prescription medications in 2021, such as an antidepressant or a sedative, almost daily for 2 weeks or more for an emotional or personal problem, compared to 10.3% in 2019. Next, let's look at changes between 2019 and 2021 in functional impairment in various aspects of life due to their emotions. Across all aspects of impairment measured, we observed similar increases between 2019 and 2021, from approximately 20% to approximately 26% of California adults reporting impairment due to their emotions, whether that be in their work performance, social life, relationship with friends and family, or household chores. And as has been observed in other studies, the impact of the pandemic is especially pronounced for young adults. One very concerning measure of this is the percentage of young adults age 18 to 24 reporting serious suicide ideation, which rose from 23.7% in 2019 to 30.5%, or almost 1 in 3 in 2021. And by comparison, for adults age 25 and older, the rates were 12.7% in 2019 and 17.3% in 2021. Aside from other life disruptions and stresses more directly linked to the pandemic, we also measured in the 2021 CHIS those who reported experiencing unfair treatment during the pandemic due to their race or ethnicity. And we explored the linkage to mental health. Among all California adults who experienced unfair treatment, more than 1 in 4, or 26.9%, reported experiencing serious suicide ideation. And 1 in 3, or 34.2%, experienced serious psychological distress, which is twice the rate of all California adults. Starting in 2021, the CHIS began collecting information on adverse childhood experiences, or ACEs, a set of potentially traumatic experiences that occur when we are young, and that may be the root cause of some of the most common, serious, and costly health and social challenges facing our state. With the release of the CHIS 2021, we're using an 11-question tool that was recommended by the CDC in the Behavior Risk Factor Surveillance Survey, which includes 3 separate questions on sexual abuse. And we observed that 2 in 3 California adults reported having experienced at least one of these 11 ACEs, with 1 in 5 reporting having experienced 4 or more ACEs. That relationship between ACEs and mental health is also clear, as we observed that nearly 1 in 3, or 32.3%, of those who experienced 4 or more ACEs also reported experiencing serious psychological distress during the past year, compared to 7.8% of those who had not experienced any such adverse childhood experiences. Next, we share CHIS data on adverse childhood experiences by race and ethnicity. 2 race groups had especially higher rates than the statewide rate for all adults. Black or African American adults at 76.6%, and American Indian and Alaska Native adults at 86.1%, reported experiencing at least 1 ACE. When looking at those who experienced 4 or more ACEs, we see that the American Indian and Alaska Native adults had the highest rates at 35.8%, compared to 21.2% for all California adults. The 2021 CHIS survey contains some new questions on encounters with police, including questions about being stopped by the police, being booked for breaking the law, and whether someone they were living with was ever booked for breaking the law. Asking these questions on the CHIS enables researchers to examine physical and mental health impacts of such encounters. First, when examining the number of times adults had been stopped by police in the past 3 years, we measured that 1 in 3 Black or African American adults had been stopped 1 or more times, significantly higher than the rate of 1 in 5 for all California adults. Next, we look at the mental health connections to these police encounters, specifically the rates of those experiencing serious psychological distress in the past year. Although 17% of all California adults report experiencing serious psychological distress in the past year, this rate jumps to 25.4% of adults who have been stopped by police in the last 3 years. Similarly, 24.9% of California adults who have ever lived with someone in their household who was arrested also reported serious psychological distress in the past year. The 2021 CHIS also included questions regarding climate change and extreme weather-related events, which was defined to include extreme heat waves, flooding, wildfires, smoke from wildfires, and public safety power shutoffs of electricity to prevent a wildfire. In 2021, 44.8% of California adults reported having directly experienced one of these extreme weather-related events in the past 2 years. We then asked about impacts on physical and mental health caused by these extreme weather events. Statewide, 7.5% of California adults reported physical health impacts, and 9.8% reported mental health impacts, but those rates did vary by region. In the Northern Sierra region, which consists of 25 counties, we observed that 16.6% had physical health impacts, and 23.9% had mental health impacts. This was followed by the Greater Bay Area, the Sacramento area, and the Central Coast area, which all had rates higher than the state average. The San Joaquin Valley had rates very close to the state average, and lower rates of physical or mental health impacts were observed in the Los Angeles region and the other Southern California region. And the rates of physical and mental health impacts in these regions were approximately 1/4 the rates in the Northern Sierra counties region. Last year, during the 2020 CHIS data release webinar, we highlighted some improvements in some negative health behaviors regarding tobacco use. As adolescents and young adults spent more time at home during the pandemic stay-at-home orders in 2020, it was not surprising to see declines in tobacco use. But how did this change as things opened up more in 2021? The rate of adolescent e-cigarette use actually continued to drop in 2021, down to only 1.4% of adolescents aged 12 to 17 using e-cigarettes in the past 30 days. Unfortunately, though, this trend was not the case for adults, and especially for young adults, who both rebounded to pre-pandemic levels for current e-cigarette use, 4.3% for all adults and 11.2% for young adults aged 18 to 25. The trend of rebounding increases in rates in 2021 after decline in 2020 also applied for all young adults and young adults all adults and young adults reporting use in the last 30 days of flavored tobacco products. Rates of current use of flavored tobacco products rose to 6.0% in 2021 for adults of all ages, and to 11.7% for young adults age 18 to 25, significant increases from the 2020 rates of 4.0% and 6.8%, respectively. The CHIS also measures usage rates of current or past 30-day usage of non-cigarette tobacco products, which includes products like big cigars, cigarillos, chewing tobacco, hookah water pipes, or e-cigarettes. And the rates of current users of these types of products exhibited a similar trend, dropping in 2020, but rebounding to pre-pandemic levels in 2021, with rates of 6.9% for all adults and 13.1% for young adults age 18 to 25. And the final CHIS 2021 topic that I'll highlight today that is very relevant to some Californians relates to a new series of questions about housing security. This included questions about how stable or unstable people feel in their current housing situation, and how often they worry about struggling to keep up with their mortgage or rent payments. And we found that 4.7% of California adults reported feeling fairly unstable or very unstable about their current housing situation. Young adults age 18 to 24 reported feeling more unstable than older adults, with 6.2% of young adults feeling fairly or very unstable. Older adults aged 65 to 79 and 80 years or older had the lowest rates of feeling fairly or very unstable at 3.3% and 2.6% respectively. Next, we'll look at these housing instability data in connection with COVID-19 pandemic employment challenges. Those who had lost their job due to the pandemic were 3 times more likely to feel fairly or very unstable and insecure in their current housing than those who had not lost their job, 11.9% versus 3.8% respectively. Finally, one of the benefits of including housing-related questions on CHIS is the ability to look at connections with various health indicators. And we observe one such connection when comparing housing instability with overall self-rated health. Those who rate their overall health as poor were 5 times more likely than those who rate their overall health as excellent to report feeling fairly or very unstable in their current housing situation, 13.3% versus 2.7% respectively. Similarly, those with poor overall health were 3 times more likely than those with excellent health to report that they worry very often about struggling with their mortgage or rent payments, 12.6% versus 3.8%. And now it is my great pleasure to introduce Sean Tan, a senior public administration analyst on the CHIS team, who will lead the presentation of a fact sheet released this morning that highlights findings from the new 2021 CHIS data on firearms in the home, gun safety, and gun violence. Sean?
Thank you, Todd. Hello, everyone. My name is Sean Tan. Today, I will be presenting on the CHIS Health Policy Fact Sheet regarding gun safety and violence prepared by my colleague Rachel Banawa and me. The 2021 CHIS contains a new set of questions under the gun violence module. The questionnaire module was asked of adolescents ages 12 to 17 and as well as adults 18 and over. The fact sheet entitled, "Despite California's strong gun laws and regulations, issues of gun safety and fears of gun violence remain," provides estimates regarding the proportion of California adults with guns at home, gun safety, and concerns about gun violence. Estimates are also provided for key population groups, including young adults, veterans, immigrants, lesbian, gay, bisexual, and transgender adults, and a comparison of adults in urban and rural areas. The fact sheet and appendix, as well as the related infographic, can be found on the center's webpage. Next slide. We'd like to acknowledge and thank the UCLA NCGVR Working Group, Dr. Joanne Arsenault, Dr. Marian Betts, Dr. Carrot Conran, Dr. Michael Rodriguez, and Dr. George Tita for their invaluable work and contributions to this project. Thank you very much. Next slide. We'd also like to give a special thank you to the National Collaborative on gun violence research for their support of CHIS and the gun violence module. The views expressed in this fact sheet are those of the authors and do not necessarily reflect the views of NCGPR. Next slide. According to the 2021 CHIS data, there are more than 1 in 6 or 17.6% of California adults who reported that they live with a gun at home. CHIS did not ask respondents whether respondents had owned the gun. Therefore, this percentage reflects only the presence of a gun at home. Next slide. In our analysis, we focused on developing estimates for our population group of interests who have recently or disproportionately been affected by gun violence and gun safety issues. The CHIS working group plans to release future publications, including policy briefs that provide in-depth analysis of the population groups presented here, and will also include estimates from future CHIS data years. According to the 2021 CHIS, 14.8% of young adults indicated having a firearm at home, which is a lower percentage when compared to adults 65 and older at 21.2%. We also found that US-born adults had 3 times the proportion of having a firearm at home compared to immigrants. As we can see, 22.2% of adults, US-born adults had a firearm at home compared to 7.7% of immigrants. Immigrants in this figure include both naturalized citizens and non-citizen adults. We also found that 13.8% of lesbian, gay, or bisexual adults reported having a firearm at home, which is lower than 18.1% of non-LGBT adults who reported having a firearm at home. 13.2% of transgender or gender nonconforming adults indicated having a firearm at home, which is not different to cisgender or non-transgender adults at 17.7%. We also found that 38.1% of veteran adults in California had reported having a firearm at home, which is higher than the proportion of all California adults who reported a firearm. Adults living in rural areas also had a higher proportion compared to the overall proportion of the state reporting having a gun at home at 31.9%. In addition, adults in rural areas had almost twice the proportion reporting having a firearm at home compared to 16.2% of adults living in urban areas. Next slide. Our analysis also examined some of the behaviors of gun-owning adults in relation to gun safety. We found that among California gun owners, nearly 3 in 4, or 72.5% of gun owners use a cable lock or lock container to store their guns, while 1 in 5, or 19.6% of adults use a trigger lock, and 1 in 3 adults, or 7.9% of adults use a combination of a trigger lock and a cable lock or lock container. Gun safety experts suggest that the use of only a trigger lock may not be sufficient to creating a safe home environment because guns with a trigger lock can still be accessible to those who may not be permitted to access one, particularly children and adolescents. The 2021 CHIS also indicated that 1 in 3, or 7.7% of gun owners kept their firearm at home loaded and unlocked. Next slide, please. Further elaborating on gun safety, we found that 1 in 7, or 13.9% of veterans kept a firearm at home loaded and unlocked, which is twice the percentage of non-veteran adults in California. The percentage of immigrant gun owners who kept a firearm loaded and unlocked was lower to those of US-born adults, 5.5% versus 8.2%. For LGBT adults, 9.3% kept a firearm at home loaded and unlocked. And among adult gun owners in rural areas, 9.7% reported keeping a firearm loaded and locked. We are unable to provide statistically stable estimates for young adults as well as transgender and gender nonconforming adults due to small sample sizes for this question. We look forward to future CHIS data collection on this measure to provide stable estimates. Next slide. Finally, we looked at how concerned California adults are about being a victim of gun violence. Level of concern was measured as a scale from not at all worried, not too worried, somewhat worried, and very worried. In this presentation, we provide estimates for adults who are very worried about being a victim of gun violence, but we provide a complete estimates table in the appendix, which is available on the center website. Our analysis indicate that 1 in 8 or 12.9% of adults reported that they were very worried about being a victim of gun violence. Among certain population groups, we found that 24% of immigrants reported being very worried, which is 3 times more than the 7.7% of US-born adults. 14.3% of young adults indicated that they are very worried about gun violence, which is a figure that is comparable or similar to other adult age groups. 13.7% of LGB adults also indicated they were very concerned about gun violence, which is similar to non-LGB adults at 12.6%. Again, we are unable to provide the stable estimates for transgender and gender nonconforming adults regarding this question. We found that about half of adults in rural areas compared to adults living in urban areas reported being very worried about being a victim of gun violence. As we can see that 6.5% of adults in rural areas and 13.5% of adults in urban areas. Lastly, 4.4% of veterans indicated that they were very worried about being a victim of gun violence. That concludes my brief presentation on gun violence. I will now turn it to Dr. Ponce.
Thank you. Thank you, Royce. I would like to just checking on the tech team to please help me start my video. Okay, if not, I'll continue. So here we go. It goes. Yeah, I'm back. Thank you so much, Sean, for presenting that information, and to Todd. So all of this data does not just sit on the shelf. We really pride ourselves in democratizing the data and making just available to the public. Our dissemination aims, though, are a balance of ensuring that we protect respondent confidentiality, but of course, democratizing this by putting data in the hands of those who can use it. We do reach a large and diverse audience across divides of technology, skills, and resources. And I'll show you the different ways of dissemination. We have something called the Data Access Center, and Andrew Youngke, who has actually been answering some of the questions on chat, is a director of that center. It is a secure network that holds data and analysis. And this is what houses what we call the restricted data. So data that has information that is high in disclosure risk and sensitivity, for example, the address of the respondent. We have a public use file that is freely available, downloadable. The 1 year you can download on the spot. The 2-year data requires more of a description of what you're doing and then a review, but you should be getting that fairly quickly. It is a bit pro forma, but is a way for us to understand the use of the 2-year puff. Then if you just really need estimates at your fingertips, I know one of the respondents was asking about some cross tabulations with race. You could use Ask CHIS. It is an award-winning online health data query tool, and it is free, and you could use the tool to make comparisons, make crosstabs. You can limit the subgroups that you're interested in, and you can download that as an Excel file or email to you. And you can also make charts, bar charts, and pie charts with it. You can also pool the data, because often the groups you may be interested in getting insights on require several years of data to pull to ensure that the estimates are statistically reliable. And then we have Ask Just Neighborhood Edition. This launched back, I think, in 2014. It's a really cool tool. It is, what advocates and users said, Ask Just is great, but I also want to have more granular estimates, not just at the state level or at the region or county level, but what's going on in my neighborhood. And our geographic measure of that, imperfect, but at least it gets at the census tract level and the zip code level. So it's not all of the 200 plus variables that we have in Ask CHIS, but it is a curated set. It is pre-digested, but it does allow you to look at estimates across census tracts, zip codes, cities, and counties as well. We have that tool also in Spanish. Then we have health profiles. Again, advocates said, the tools are great, but I just want to print something in a PDF file so I have something available when I go visit city council member, or I visit a legislator, or I want to show this to a group of community advocates and community members. So we have a health profile section that has PDF files of key health indicators. And then all of this, then we try to support through tutorials and through our educational program, as well as YouTube tutorials. So let's go to the next slide, please. I think we'll talk more about later. So CHIS has 56 geographic defined strata. I think one of the goals of CHIS, with its large sample of 20,000 households per year, is to ensure that we can make sub-state estimates, not just state level estimates. So there are 58 counties in California, but some counties are very small, like Alpine. So we do group. And then there are large counties such as Los Angeles and San Diego County. And there that we have what's called sub-county strata. So for Los Angeles, we have 8 service planning areas. In San Diego, we have 6 health regions. And then the remaining 39 counties, they have their own individual strata. So when the counties get smaller, then they do require, or we start getting into, sub-county estimates, then you require 2 years of data to produce these modeled estimates that I had referred to in the Ask Just Neighborhood Edition tool. Next slide. So we cover these geographies, but across different products. So we can look at the state and we can look at the counties using Ask CHIS. And so that's the tool that you would use if you're interested in overall state estimates and county and region specific estimates. You would use Ask CHIS. But if you wanted to get more granular in geography, looking at assembly, Senate, congressional districts, cities, zip codes, and census tracts, actually that's been available for, I think, about 2 years now, then you would use Ask CHIS Neighborhood Edition. And I remind everyone that Ask CHIS Neighborhood Edition are modeled estimates. They are not direct estimates. So they are modeled estimates using something called small area estimation methods. So it is updated every 2 years. And we've been slowly adding these modeled, the set of modeled estimates in Ask CHIS Neighborhood Edition. So if you are on our e-blast list, then stay tuned for all of our updates. It does currently contain 2019, 2020 CHIS data. And 2021 CHIS data is direct estimates are now available in Ask CHIS. Next slide. So Ask CHIS Neighborhood Edition, this is the tool, the web query tool that houses the modeled estimates, the small area estimates, with a set of variables from CHIS, but also some variables from the American Community Survey and air pollution estimates from the California Air Resource Board. So this is a visual of, if you go to Ask CHIS, Neighborhood Edition. We call it AskCHIS NE. This is the visual of what you would get. Very different look from AskCHIS because of the mapping capability. But we also have some other capabilities, as you can see in the second panel of this slide, with the wall of looking at the boxes and squares, looking at the distribution of federal poverty level, for example. You can ask to look at indicators for all the indicators that we have, but the tool does have some limitations in that you can only ask for 5 different areas. And if you wanted to get all of this information, then please contact us. And we do have something called an API that can be purchased to get at all of these model estimates. And the reason why is because of the estimation and computation effort that was used in creating this model estimate. So do contact us if you are interested in this, but it is freely available. If, say, you only wanted to compare 5 areas, you can interchange those areas, and you can always compare it to the state. So next slide, please. This is what I was referring to in terms of the tutorials, is that we do have an on-demand learning center. They're digestible 10-minute segments. You can access them anytime. It gets at how do you do a basic query? How do you display the data? How to export your data, the confidence intervals, what confidence intervals are, what pooling gets at. The statistical stability. So I do encourage you to use these on-demand learning centers. And as I said in the very beginning of this presentation, we also have a scheduled training, a formal training on using the different tools that we have in the California Health Interview Survey. Next slide, please. Because the pandemic really required understanding of the toll in the populations and more real-time data, not waiting a year for data, and also contextualizing this data in what's going on in a county in terms of some of the social determinants of health, and also in looking at some specific racial ethnic groups. So we have dashboards, and they are available under health profiles. And it's the 2020 to 2022 CHIS COVID-19. These are preliminary monthly estimates. Never before until the onset of the pandemic did we release CHIS data in the same year. I underscore that it's preliminary monthly estimates, so they could change once we have the whole year of data to present, but it does address the need for the timeliness of data, particularly on COVID and COVID impacts on Californians. Look at COVID-19 rates and risk factors. We have COVID-19 rates and risk factors by California counties. Next slide. So I have 10 more minutes, so sorry we went over by 5 minutes, but do visit us at chis.ucla.edu. What I have here are the names of the marvelous CHIS team that made it possible to release data today. There are also countless of people that are from the Center for Health Policy Research that made this happen. And of course, the CHIS respondents, our advisory board, all of the committees that worked with us in developing the content of CHIS. I thank you. And I especially also thank Todd Hughes, the director of CHIS, who was the lead conductor in making sure all the different pieces were happening to get the data out to you today. So now we're open for Q&A.
Thank you, Ninez. Good afternoon, everyone. My name is Tiffany Lopes, and I'm the Director of Communications here at the Center, so I'll be going through some of the audience questions. If you do have questions, please go ahead and use the Q&A function in Zoom to ask them. We have folks from the CHIS team who are responding to some of them via the Q&A, and also will be answering some of them live now. So first question, How do your CHIS sample and findings compare to the California BRFIS?
I'll take a stab at that first. So we as Todd mentioned, there are a number of variables that we have and estimates that we have. So we haven't lined it up, each variable with what BRFIS has. I think the key takeaways are that BRFIS is adults, CHIS has data on adults, children, and adolescents. The larger sample of CHIS allows for sub-state estimates and for looking at estimates for smaller populations. So I do think that we do try to look at BRFIS and other surveys in California and across the nation in developing content. And also if there is an estimate that may seem unusual, we do try to triangulate or look at our data, but it's a different survey in that it includes content that may not be included, and BRFIS may include content that we don't have, but they are both probability based.
Thank you. We've got some questions about linking this data to other surveys. So are there other state or federally sponsored surveys that can link with the CHIS? And also, are you currently working on linking this data to other individual level data sets and share the linked data in the future?
Should I begin, Ninez, and then you can?
Yeah, because of course I would say I love that question, but
Yeah, no, we do love that question. Certainly there's a lot of, attractiveness to finding ways to improve the methods that with the CHIS can be used to do these kinds of linkages. Let me start by saying what's possible right now. So currently, if you have a data set that you would like to look at, building into a model with the CHIS data, it generally has to be done geographically. It can't be done at an individual level. So, if you have a data set with tract level data and you would like to merge that in with CHIS data and create a model and give you some output from that, then that is certainly something that we can do through our data access center, because we do geocode our individual CHIS respondents down to the census tract and block group, zip code. Any of those are possible ways of merging in data. Now, at an individual level, there is interest and some early exploration for ways that the CHIS can do that in the future. And it is on our to-do list to continue some work to further those explorations. But unfortunately, there's no current direct linkages available. It would require seeking permission from respondents to conduct those linkages, which we currently do not have in the survey. But there's a number of things that we're interested in exploring on that front.
Thanks. And just adding to that, is it possible for folks to use this public data and link it to other area level data sets?
So on the public use file, there are no geographic indicators below the state level. So you can't do that linkage on your own independently. The geographic identifiers are only contained within our secure data access center so that we can preserve the confidentiality of our respondents. So definitely do the link that Tiffany shared about Get CHIS data that has all the information about how to access an application for the data access center, and we'd be happy to explore various research projects in a collaborative way with you.
Thanks, Todd. How representative of the nation do you consider the CHIS survey? Can we extrapolate at all, specifically the gun violence questions, or would you say this relates to California residents only?
So I think this applies both to CHIS and other data sets that are California specific. And it's so some of the the populations that we represent, for example, there are areas in the rural north, and that may look like some states in the nation or some areas in the nation. There are experiences culturally of population groups that may be applicable to the same racial ethnic population groups in other states. So I do think it depends on the research question, on the researcher's question, and how much they think it is generalizable to other states or other populations in other states, but it is more of an artifact of, is California different? Is California exceptional? Might California be, though, have enough within state variations that, it's like California is not all, Silicon Valley and Hollywood. So that it's also a very agricultural state. So I think that there are features of the state, and the state's population, that could be of utility, that could be useful in its application for generating insights in other places.
Thank you, Ninez. What level of geography is the gun violence data available at? County, city, and will Ask Chiz Neighborhood Edition include topics pertaining to firearms?
Maybe to help with that, let me go back to this slide that shows the individual sampling stratum. So these are all of the strata for which we produce direct estimates that were released in the Ask Chis platform today. So you can go into the Ask Chis platform and generate individual county level estimates for any of the indicators on the survey that are in Ask Chis. For each of these kind of lighter blue counties, there are 3 of these multi-county strata that Ninez referred to. So you could get one estimate for these multi-county group, each multi-county group independently. And then there are the 2 counties that we do sub-county level estimates. So in Los Angeles, it goes down to the service planning area, and for San Diego down to the health regions. So that's the current data that's available. We are planning to work towards some gun violence indicators in the Ask Chis Neighborhood Edition platform once we have accumulated 2 years of data to be able to begin that work, and that would then be able to produce estimates down to the census tract level. But currently in the 2021 CHIS data in the Ask Chis platform, it's each of these 56 geographically defined strata.
Thank you, Todd. Speaking on the 2 years, so some of these new data on firearm safety and concerns about gun violence, police encounters, and climate change and health are really timely and interesting. Are there plans to continue asking these questions in the coming years? And also, how do you determine which questions to keep and which questions to remove?
Well, so I think it's going to be me and Todd answering this. In one of my earlier slides, I said CHIS is a collaborative project with all the sponsors, the California Department of Public Health, California Department of Healthcare Services, First Five. So we have government, state sponsors, we have local, we have county sponsors like San Diego County, we have foundations, the California Endowment, California Healthcare Foundation, wellness. So there's over a dozen funders of CHIS, and it is to some respect funder driven and funder interest, but we also make sure that we have people in the room that aren't funders but really care about segments of the population, particularly those that are marginalized. So I think in terms of content, we have a process. And if there is interest in some of the questions to continue, that please let us know and we can go back to our funder. The questions on the module on gun violence was only for 2 years. And then so we are hoping to discuss that with our funder to continue. So I'm going to give it to Todd.
No, I absolutely agree with your assessment of that. Yes, thank you.
And, it is 1 o'clock. I know that we're technically out of time, but we also talked about the possibility of extending for a few more minutes to answer some more questions. If Ninez and Todd and Sean, you're open to that, I can continue with a few more.
Sure.
Happy to, yeah.
Great. So some questions regarding methodology. I see from the methodology reports that you had higher non-English completes for 2021 than individually each year in 2019 and 2020, even before the prepaid cell sample. What does CHIS contribute this non-English completes boom for, given plus 90% are web completes? And then a second part to that question is, it seems from the methodology report that prepaid did well for adding Spanish language completes. What about for 18 to 24-year-olds or Black or African Americans? Did many of these get pushed to web?
Yeah, I'd be happy to answer that. Thanks for the question. So there are a number of strategies that we use to try to reflect that diversity, especially the linguistic diversity. And there were some efforts that were especially helpful in 2021 as we went through our various efforts. So specifically, we attribute the increase in non-English language completes in 2021 due to a couple of key things. Number one, sampling enhancements. So the first way that we did that is we had 2 years of previous CHIS data from 2019 and 2020 in an address-based design, where we had proven in the initial development of some predictive models to help to identify which addresses were more likely to have a language need, and then increasing the sampling rate from those addresses in order to increase the total number of response that we would get from a linguistically diverse population. And so that was very helpful to refine those models after being able to look back at the first 2 years. And we express our thanks to our colleagues at SSRS who really helped to further develop those models. The second component we attribute is a modified way in which our call centers handled language needs. So first and foremost, we actually, when we had predicted based on the predictive modeling that a given address might have a language need, we then routed that address to that case to a bilingual interviewer from the very first call attempt that was made to that household. So rather than letting all of the cases go randomly to whatever interviewer was available, and likely having a monolingual speaker answer the phone or make the phone call, we used bilingual interviewers when we could predict a likely language need for a given address, and that was also very successful. Prepaid cell did very well for adding Spanish language completes, as well as young adults and some for Blacks as well. I don't have the distribution right now of how many of those were actually pushed to web. Most of those were done by telephone because they were a cell phone, a prepaid cell phone random digit dial sampling method.
Thank you, Todd. Is it feasible that we could reach out to a specific community, or do we need to collaborate with the center and engage them in the process of developing, implementing, and evaluating intervention programs to really make impact?
I think it depends on the intervention program. I mean, there have been researchers who have used CHIS as sort of the natural control group. If they had an intervention for a specific, say, the health delivery system, and then they wanted to look at how the impact, how their health delivery system demographics compare to the general population in the service area. Also looking at, again, using CHIS possibly as, again, this comparison. It is a population-based surveillance of key issues, not an investigator-initiated tool for evaluating interventions and the impact. But we can certainly work with you on how we could look at some, quasi-experimental approaches with CHIS. So you would email, you can email me on that, nponce@ucla.edu.
Thank you. I am interested in zip code level data. Currently, I'm using CDC Places data sets for my project. Based on CDC Places documentation, they also use small area estimates, and some of their indicators are based on BRFIS. Since CHIS has a larger sample size than BRFIS, it appears that CHIS's small area estimates. Oh, I lost the second bit of that question.
I can answer. I think what they're getting.
Oh, sorry, may be more reliable. To what extent do they differ?
I think it's, first of all, I'm a big fan of the CDC Places data sets. I think you could use, and they have more variables than what we have. So I can't speak about reliability. I think the modeling approach, we use a multi-level modeling approach. We do have some papers we can send to you on the actual approach, our estimation methods. and then how that compares with CDC's. You could use the places data sets and link it to individual data in CHIS. And that would be, again, a possibility. You'd have to use the restricted data. In terms of which one to use, I think it's your call on if the indicator of interest is in the places or in CHIS, or in your own assessment on methodologically, which one seems more appropriate.
Thank you, Ninez. Someone mentioned some ethnic groups racial and ethnic groups are underrepresented. Can you explain why that is and talk a little bit about the oversampling?
Well, there's a number of efforts that CHIS uses to represent each of those groups. Cooperation rates differ by different groups, and so it's always a challenge to obtain cooperation from every household that's selected for the survey. And so the ways that we address that is by increasing the sampling rates from households that we think will likely be representative of characteristics that are less likely to respond. And then we incorporate that with other data sources in our weighting strategies to make sure that even if we have a lower count of interviews conducted for a given racial or ethnic group, that they are weighted in such a way that they are representative of the statewide population in all of our data. So it's through the tools of statistics and through some creative efforts for data collection, we do our best, and then we're continually looking for additional solutions as well as additional funding to try new creative solutions to try to increase representation from some of these groups.
Thank you. And then someone, just as you were responding to that, asked in the chat, can you speak to representativeness of people with disabilities?
I don't think we have any 2021 data right now at our fingertips that we could answer that question in this webinar.
Thank you. So those are all the questions we have time for this afternoon. Thank you again so much. Sorry.
I just want to say that coverage, what's called coverage bias, is top of mind for us. So we do think, so for example, when we went to address-based, push to web, we kept the telephone component to make sure that we reached people who didn't have a computer, who couldn't read the computer, couldn't read the results. So we do try as best as possible to reduce coverage bias. And as Todd explained on the ways that we've tried to do it.
Thank you, Ninez. So I dropped in the chat one last time the link to the GIST data user training that we're having on Wednesday, October 26th. If you want to learn how to use this data, we are going to be there for 90 minutes to teach you how to do it. So also just a reminder, we will be posting the recording of this webinar on our YouTube page with closed captions in the next 2 weeks. If you'd like a copy of today's presentation, you can email us at healthpolicy@ucla.edu. Again, I just want to thank you all for attending the 2021 California Health Interview Survey data release, and have a wonderful rest of the day.
Thanks all.
Thank you.